What's the gap in terms of adoption of value-based care models? Is it finding the right counterpart on the provider side that's willing and able to take to take on that kind of reimbursement model? Is it the geographic dispersion of your employees? Is it the carriers and the plans that they're and the flexibility that they have on their side? What are the key limiting factors?
It's all of the above, all of the things that you mentioned. And I'd add a couple of more. One is tenure, right? Most employers aren't keeping an employee for 20, 25, 30 years. And so they don't have a natural incentive to manage care over the long term. And this is a key incentive misalignment in employer-sponsored insurance generally. I also think it's worth acknowledging how complex it is to adjudicate value-based incentives, right? They don't manage themselves.
Welcome to the Scale Healthcare Technology and Innovation Podcast, where we explore how innovative technology is revolutionizing U.S. healthcare. Hosted by Jason Schiffman, President of Scale, we sit down with industry leaders to uncover the strategies, breakthroughs, and technologies shaping the future of care. Join us and subscribe as we dive into the cutting edge of healthcare innovation.
All right, welcome to the next Scale Community Technology and Innovation within Healthcare podcast. I am pleased to be joined by Rivka Friedman, Managing Director at Morgan & Health. Morgan Health is a unit within JP Morgan that is focused on investing in innovation with the employer-sponsored healthcare market. So Rivka, welcome.
Thanks, Jason. It's great to be here.
So for those who are less familiar with Morgan Health, why don't we begin maybe just a quick introduction to yourself and your background, and then also Morgan Health and the mission and focus of the entity.
Sure. So Morgan Health was founded in 2021. And we, as you mentioned, are a line of business within JP Morgan Chase. We sit fully within the bank. And the purpose of Morgan Health is to improve quality, equity, and affordability in employer-sponsored insurance. And as some of the listeners to this podcast may know, JP Morgan has some history in working in this space. They launched Haven several years ago, jointly with Amazon and Berkshire Hathaway, which was focused really on curbing employers' healthcare expenses. And when that effort wound down in 2020, JP Morgan decided to launch Morgan Health on its own. And our focus is different from Haven's. We are focused on the employee experience in healthcare, both the quality of outcomes and equity of those outcomes, and then also affordability, how healthcare hits employees in their spending. And the way that Morgan Health is organized, we have a fund, we have a balance sheet fund. So we invest, our initial tranche was $250 million in balance sheet capital to invest in innovative companies that are focused on serving the employer-sponsored insurance space. And we also have an innovation studio, which is the part of the business that I lead, which is focused on doing data analytics and research, and also running pilots of innovative solutions in ESI, or employer-sponsored insurance, to really test what works and then help scale successful innovations across the sector. And by way of background, I came most recently from the CMS Innovation Center, or CMMI, which was testing many similar innovations in the Medicare and Medicaid space. And one of the most interesting things about my 3+ years at Morgan Health has been understanding the ways in which ESI and Medicaid and Medicare are different and the ways in which they are similar.
Would love to hear more about that component.
Yeah, sure. I mean, I think in terms of the key difference, I sometimes think of ESI as the Wild West. You've got hundreds, thousands of employers, each operating a small, sometimes not so small in our case, health insurance business in addition to their core business. And that creates opportunity for innovation. Different employers try different things, and we can learn a lot about what works. But it also creates some misaligned incentives in a way that Medicare in particular does not experience. There are, of course, Medicare Advantage plans, but Medicare as a program has people from 65 until they die and has a lot of uniformity about that benefit. Whereas in ESI, there are many different styles of benefits, many different styles of healthcare delivered, and the like. I think the more surprising piece has been the ways in which these products and plans and populations are similar. So our Morgan Health recently did some research on maternal healthcare in America. We looked at quality of outcomes. We looked at affordability of maternal health care, or the lack thereof in this case. And one of the interesting findings from that work was that there is significant overlap in the population of women on employer-sponsored insurance who also qualify for nutrition assistance, or for in this case, it's 13% of people in ESI who are also receiving WIC. And so if you think about the overlap between the Medicaid population and the ESI population, which is not intuitive, but is quite present, I think you can take away a lesson that innovation in Medicaid for maternal health, but also for many other things, may have transportability or exportability to the employer space.
So let's use that as a way to kind of bridge to where you have been focused at Morgan Health. So today, I believe you have 8 portfolio companies. And so what are the areas that you're focused on investing in? You mentioned maternal health, but what are the key drivers that allow you to influence, that you're focused on, that allow you to influence affecting the employee experience as it relates to healthcare?
Yeah, great question. So when we launched Morgan Health, we started by looking at JP Morgan Chase's concentration to try to understand where we had large populations that we could offer new innovative solutions to at scale. And we took that geographic approach because JP Morgan Chase is concentrated in 7 main markets. Columbus, Ohio, where we launched our first primary care investment, was one of our largest markets, and that's why we launched it there. So that was one thing we did, is really try to understand how JP Morgan Chase is concentrated and where we might be able to deploy innovations across a large group, knowing that we were focused on scale. The other piece we did in parallel was thinking about the healthcare system as a combination of categories of care, types of incentive, groups of providers, and then groups of employees. And with that broad analysis complete, we decided to focus on key areas of healthcare where we knew there was opportunity to improve health outcomes and disparities by geography, income, race, gender, and the like, and also where there were significant affordability opportunities, so opportunities to improve affordability. We landed on primary care because despite a proliferation of different primary care models and years, arguably decades of research on the promise of primary care, we still saw significant gaps in our population's access to primary care. And so it's in many ways the most obvious place for us to start, and it's where we started. We also branched out then from primary care proper to something we've started to call primary as specialty care. When employees have a specific condition, whether it's cancer or a chronic disease that requires specialist intervention, or even they're pregnant and they're going to have a baby, in many of those cases, the specialist is operating as that person's primary provider of care. And we saw and continue to see opportunity to launch and scale innovations in care for those populations and for those episodes of care. So those are 2 main places where we've been focused on the care continuum. I'd highlight, and maybe we can talk about this also, that there are different populations of employees and different populations of employers that have unique needs. And so one thing we've been thinking about more is those populations of employers. JP Morgan is obviously a jumbo employer. We spend over $2 billion annually on healthcare. Small and medium-sized businesses have a healthcare budget, fraction of that size, and they also have very limited resources to use when picking health insurance. And we have realized over the past year and a half that there is opportunity for us to support them by scaling innovation in the small and mid-sized business insurance and care sector.
So what does it mean for, if you think about whether it's primary care or specialty care, what is the employer element to the strategies that you've deployed? So what is that extra coordination or extra service that links that primary care and makes that experience unique for the JP Morgan employee who's under this program versus myself going to my primary care outside of that program?
So that's part of what we're testing. We're trying to figure out whether if an employer like JP Morgan Chase decides to invest in making better, more comprehensive primary care more accessible to employees, do people use it more? Do they have a better experience? And do they see impact on their health outcomes? That's the big test. And so how we've been testing that is that we did invest in upscaling an existing on-site clinic in Columbus to offer more comprehensive care. To be specific here, Vera Whole Health, which is part of a PRE, is offering on-site mental health and screenings. We've been working with them in a significant way to identify and address patients' social needs, so food needs, utilities support, transportation support, and the like. And they have also a partnership with a local primary care practice that has significant experience in value-based primary care programs. So they've been able to benefit not just on the care delivery side from innovations in care delivery, but also from that practice's innovation and in payment experience. And what we're testing is, do people get more from that primary care than they would get otherwise? And I think what we're seeing is early promising results. So Vera has an incredibly high net promoter score. People really love their experience. And people who are using Vera for a significant portion of their primary care are seeing some positive results, like increased screenings. And it's very early, but we think we are seeing some effect on downstream utilization. I think the key question for this initiative and for other primary care initiatives is, how do you expand uptake? How do you really engage not just the people who are most likely to use this product, but everybody? And one way that we've been testing doing that with Vera is by holding them accountable for total population health in Columbus. So we're not just focused on the people that Vera touches. We've been pushing Vera to really engage a broader swath of the population than would come in otherwise. I do think that's a key challenge. But at a high level, what we're looking at is, if employers invest in this better, more comprehensive care, will it have an impact that we hope to see?
So it sounds like one of the criteria is density. So you mentioned a couple specific geographies where JP Morgan has a lot of employees, and those were great pilot grounds for for these initiatives. It sounds like another component was primary care. It sounds like a third component would be on-site care. Are there other key components, reimbursement models that are attached to these, other types of care coordination solutions that are relevant, specialty specific programs that you're particularly focused on? What are the key criteria that you associate with correlate with success?
It's a good question. And I'd say data are still early, so I can't say that these things correlate with success. But what we're watching is whether, maybe to address a couple of your pieces simultaneously, both does added investment in care that people aren't getting on their own make a difference? And also, what are the components of care that people are most looking for? What modalities of care are most likely to engage people who wouldn't otherwise engage? What payment models and systems will best align incentives between the provider of care, ourselves as the employer, and then, of course, the employee? And these are just some of the pieces we're testing. So to get specific here, you mentioned on-site care. We talked a little about the Vera clinic in Columbus. We've also looked at virtual only and hybrid, so virtual and in-person primary care models as an opportunity for innovation. There's clear evidence that people are interested in engaging with providers virtually. I think we saw this peak during the pandemic. It has since come down in the sense that we actually survey our employees on healthcare, and one of the interesting findings was that a desire for virtual care was at its highest in that period. And now people are really interested in care that is available both virtually and in person. And so we're working with Vera, and we're also looking at other partners that can offer that bi-modality access to care. And then I would just mention, I think in the employer space, value-based incentives have been very slow to proliferate, much slower than in the public payers. And I think there are a lot of reasons for that. One of them is, again, each employer is operating on their own, and the incentives that a carrier, so a health plan or a vendor has to introduce value-based incentives are not particularly strong. So we've been working to iterate on some value-based incentives internally, both in our relationship with Vera and in some of the other partnerships that we have. And we're going to be publishing on that experience later this year as we learn both what works for our population and also what is scalable with limited resources.
What's the gap in terms of adoption of value-based care models? Is it finding the right counterpart on the provider side that's willing and able to take to take on that kind of reimbursement model? Is it the geographic dispersion of your employees? Is it the carriers and the plans that they're and the flexibility that they have on their side? What are the key limiting factors?
It's all of the above, all of the things that you mentioned. And I'd add a couple of more. One is tenure, right? Most employers aren't keeping an employee for 20, 25, 30 years. And so they don't have a natural incentive to manage care over the long term. And this is a key incentive misalignment in employer-sponsored insurance generally. I also think it's worth acknowledging how complex it is to adjudicate value-based incentives, right? They don't manage themselves. And so you have a value-based incentive, even if you have a performance guarantee in a contract for a partner's achievement on a quality measure, you have to then go look at your data to validate those data. You have to check the current quality data to make sure you have an accurate benchmark. You've got to measure those things. That takes a lot of work. And we're doing that work internally, and we're lucky to have the resources to do that work. But it's not lost on us that most employers don't have the kind of resourcing to do that process for every partner every year. And so one question we've been grappling with is, what is a scalable approach to this that doesn't dilute the incentive to improve healthcare quality?
It's interesting because we live and breathe on the provider side, and when we think of payers, we typically think of Aetna, and Cigna, and UHC, and we spend very little time. It's beginning to change, but very little time thinking about the employer and what is our relationship with the employer. It's a much harder market to go after. You're dealing with lots of employers versus a network group of payers, and you're dealing with infrastructure that exists on the carrier side that is being built on the employer side. And and then on the employer side, when we think about healthcare, our experience is mostly, here's your 10% annual increase in cost and how much that gets held by the employer versus passed through to the employee. What tools are you seeing in the market that are empowering employers to think more intelligently about healthcare and their employee-based consumption of healthcare versus for most of us is a black box in terms of what our employees are consuming and what options we have to be more proactive in advancing and making it for a better healthcare experience for our employees.
Yeah, it's a great question. And maybe I'll answer in two completely different ways. So one, you mentioned the black box. I think we're seeing tremendous growth in the data sector, data storage, data management, data transformation sector. And it's still really early days in terms of employers embracing some of those newer tools and solutions for managing their data. But I do think, a little crystal ball here, I think 5, 7 years from now, employers will be taking on more of those tools. And probably there will be even more awareness than there is today that the convenience of being able to generate a report on the population or on cost by healthcare bucket, the convenience of that, we are trading off for accuracy in ways that make it really hard to get a clear picture of what's happening in healthcare in our population. And so I think that's one place where we're seeing a ton of innovation is upstart companies that are saying we can do a better job of warehousing your data, storing them consistently, of applying consistent definitions that are aligned with industry standards so that you can actually know who's a diabetic or who's actually pregnant or who has cancer and what has their pattern of utilization look like for their cancer experience. That's one. And I think related is companies that are applying some logic to actually tell us what good looks like. One of those companies actually we've invested in, it's called Embold. And Embold is a provider quality company. So they have proprietary algorithms to help anybody, a carrier, an employer, understand which providers are delivering high quality care according to a range of criteria. So I think that's together, you take those, that's one category where I think we're going to see tremendous innovation over the next decade. But a second category that I think addresses what you were asking is companies that are putting the power in employees' hands, right? And some of the health plans that you mentioned have products like this. Surest is a great example, but a product that says to an employee, you choose. We'll give you some data, whether it's cost data, quality data, or other, and you decide. And we'll also structure incentives to drive you to choose the highest value option. And I think we will see proliferation in those types of products that sort of bridge the trend of driving toward more affordable health plans, which is happening, with the trend of N of one medicine or personalized medicine, where it's not just here, we'll slap an option on and you can take it because it's cheaper, but it's for you. And so I do think we'll start to see more innovation in the space of giving consumers, patients, useful, actionable data to make better decisions.
Yeah, I mean, it's interesting because the cost always gets the headline, but I would imagine that employees have more needs and desires than just cost, although I'm sure cost is at the top. So what are the priority outcomes and objectives that you think we need to focus on in addition to cost to improve employee healthcare experience?
Yeah, I mean, certainly, I think it's hard to ignore the importance of affordability. We have heard various reports about premium increases last year. It sounds like average was two digits. And we have heard from some small businesses who saw their premiums increase 30%. So we can't scoff at the affordability challenge, which is only going to increase as GLP-1s become more common, as we start to see cell and gene therapies come online and get more coverage, et cetera. That said, I do think there's this much more black box question of what are we getting for the dollar we spend that some really interesting companies are trying to unpack and then improve. So I mentioned Embold Health, which is focused here. I think they'll tell you, most people think they have a good doctor because they got a recommendation from their friend, and your friend's favorite doctor isn't necessarily delivering the highest quality care. They're working to unpack that. Another example is from a company called Centivo, which is also a company in which we've invested, which offers more affordable health plans by negotiating discounts in a specific market with a high quality provider of care that is generally a large system that has significant footprint in the market, and then going to local employers and saying, look, we have this great contract with a provider that's demonstrably high quality. It's also cheaper than the alternatives. And they're seeing some nice traction of that approach, where instead of saying to an end user, here, you look at the data and make a decision for yourself, they're sort of packaging and curating that experience for employees. But I do think we're going to see a lot of innovation in the space of let us help consumers understand what good looks like beyond just cheap.
We spent a lot of time with provider MSOs that have over the past 5 to 10 years grown up quite a bit. They're larger in size. They're far more sophisticated in terms of their operations, their data analytics, their adoption of technology, their care programs, their scope of services. And so the one, interesting part, I had a conversation with the CEO of a cardiology platform a couple weeks ago, and what stood out to me is it's a $300 billion market, cardiovascular care. The estimation is that 30% of the care that's delivered is avoidable. And their focus is currently cardiologists capture 15% of the dollar, and the other 85% of the dollar goes to hospitals, to pharma. And so they have developed a care delivery program and also a reimbursement model that allows them to participate in a broader portion of the dollar. And so risk-based reimbursement, bundled care, things of that nature. But the system benefits as a result as well. These patients are being seen high quality, lower cost environments across the cardiological care delivery spectrum. And so with that, I am optimistic that a lot of the solutions to providing accessible, high quality, lower cost care exist in the market. And I think one source of those solutions comes from these specialty players that have advanced and are now, at least regional, if not national players, and are just much more organized in their care programs. What role do those organizations play in solving some of the same objectives that you're focused on? Are they helpful? And are they on your radar? Are they on employer radars?
Yeah, that's such a good question. And I do think that certainly at a high level, we're all rowing in the same direction. They are working to improve the standard of care, lower the cost of care by aligning incentives on the provider side. In our early days at Morgan Health, we did a lot of exploration of whether we could, ink a direct contract with a provider in an area of concentration for us, or otherwise directly align incentives between us and an entity that was providing care. I think that's still an opportunity. We haven't done it for a range of reasons. I do think one of them relates to just a sense that I had and that I still have that choice reigns supreme when it comes to employee plan design. And we've been able to offer some of these innovations, but we've not yet forced anybody to use them, so to speak, or made them the only option in town. And I think in order to achieve the kind of scale that an employer and a provider entity would want, in order to make it worth the effort and the resources to ink a direct contract, you'd sort of need to make that the only option. And so that's maybe my bear case
Yeah.
for greater direct partnership between providers and employers. Having said that, I mean, look, it's the prices, right? There are a lot of pieces of healthcare that are broken, but there's really no question that one of the biggest, if not the biggest, is that prices they're really high and they're often irrational. It does seem like there might be an opportunity for employers in unique circumstances or for employers with unique populations to work directly with a provider to help address that. And there's a long history of individual employers working directly on things like centers of excellence for key episodes of care that are fairly predictable and have huge cost variation, and that has worked quite beautifully. So I would, I guess, with my optimistic hat on, I'd say there are probably employers who will see an opportunity to do this as we get a little bit more customized in the kinds of care that we're offering to individual subsets of our employees.
Yeah, I mean, another challenge is I spoke with somebody who helped design a benefits program for a large employer, and they actually did strike a partnership with a provider, a health system in a local market, and they had 60,000 lives in that market, and so it made sense to partner with one of the really two of the health systems in that market. And so the natural partner was the health system. And therein lies the challenge, because a lot of times I think the best practice center of excellence for a given condition might reside within a non-healthcare system. So maybe this cardiology MSO has the right solution for cardiological conditions, and another orthopedic player has a solution for orthopedic conditions. But the health system is convenient because it has a network that covers this multi-specialty inpatient, outpatient ecosystem. And so are you seeing anything that is helping to bind together some of these more siloed centers of excellence to create a network center of excellence across these different pockets?
Sure. Yeah, there are companies that are doing that. I think CareM is a good example of a company that's offering centers of excellence across specialties. There's also a really interesting company that's doing that on an international basis, knowing that especially, many of the large companies in the States are recruiting a largely international workforce who might actually be not just willing, but interested in traveling abroad for healthcare. And of course, the prices in basically every country but the US are much, much cheaper, and often the outcomes are comparable. So they're doing that on an international basis. I think that maybe just taking those two as examples, there is a ton of white space here. Like we can really continue to innovate in sort of space of, all right, can we group of a bunch of different companies that are working on different episodes and have really cracked the code on those episodes? Can we group them together and kind of productize them for an employer? And I do think we're seeing some progress in that space.
How about your peers? So JP Morgan clearly is focused on this and is taking a leadership position. Are you seeing other large employers that have as much focus and as advanced strategies as it relates to improving employer healthcare, or is JP Morgan unique in that approach and that focus?
I mean, I think we're unique in the fact that we have Morgan Health. We have this pretty tremendous resource that is devoted specifically to identifying, testing, scaling innovations here. None of our competitors have something like that as far as I'm aware of. And when we speak to them, they usually express some amount of envy for the resource that we have here. Having said that, many of them are testing innovative solutions. One interesting thing that we've done is actually convene a number of local customers of a product that we are also a customer of in a market with that vendor to say, what is it how are we all thinking about quality of care? And might we align our definitions of quality so that the vendor only has one set of quality incentives against which to execute that also work for all of us? And, of course, you never do that around prices for obvious reasons, but there's a ton of opportunity for companies in a single industry to align around things like quality outcomes. And even, mode of care, like what is a good care model for this population? And can we all hold hands and agree that this is the right care model so that a partner can execute on a single approach that works for all of us? The other example I'd highlight is actually out of the financial industry, but Delta, the airline, has a really innovative benefits organization and also has a pretty significant team of data scientists there. And one of the things they have been interested in is figuring out how to offer primary care to their pilots and flight attendants who are often traveling very rarely in the same place for long periods of time and still have primary care needs. So that's an example, going back to our primary care conversation, of how a dual modality product can be so attractive from an employer perspective in terms of meeting their employees' needs, and also potentially get greater uptake overall because it's more available to the population.
Are you seeing coordination, best practice exchange amongst these large employers, or are you each developing your own strategies and experiments?
I think the honest answer is both.
Yeah.
So there's a ton of best practice sharing. Organizations like EHIR will gather benefits leaders around a table, have them listen to the kinds of innovations that are available today from vendors and partners that pitch, but also just exchange information on what they're doing and in a closed door Chatham House rules kind of setting, which is so helpful as folks think about, what has worked in one place that might be applicable to them. And then also this is just the key challenge of ESI, that every company is in it for themselves. And, I think that the health plans have and can play a critical role here in best practice exchange, but also in developing products that are attractive to a broader set of employers and really helping the sector productize the innovation that we want to see. I think it's our responsibility as employers to demand that. Health plans have a lot going on, and they're not going to do that unless we ask for it. And Morgan Health is trying to play our small part in that by testing things, seeing what works, and then using our experience with those pilots to really drive our conversations with our employees, but also with our health plans on what innovation we'd like to see scaled.
It's interesting that you come from CMMI because there does seem to be a lot of overlap between the role of CMMI as an innovation vehicle for the national market and the role that Morgan Health is playing as an innovation vehicle for the employer market. And, I think CMMI was one of the more interesting and impactful things to come out of the Affordable Care Act, because it's not easy to introduce the concept of innovation to a market that is so pervasive, so charged and personal to each of us, and just so big in terms of its reach. And so, are the results conclusive? Is the pathway linear? Probably not, but is the goal of innovation and experimentation worthy in and of itself? I think the answer to that is probably yes. So then what would you say to manage our expectations for what this journey looks like? So, we're 15, 16 years past the Affordable Care Act. We've probably still have as many questions as we have answers. And yet there has been progress. What should this journey look and feel like? How long does it take? How do we know if we're making progress? And what does it look and feel like?
Yeah, that's a great question. And I talk about this a lot with my team here. I think, look, the most obvious lesson that I take away from CMMI is that success takes time. No better example of that than the primary care models that CMMI ran, which improved health outcomes, but took quite a long time to do so. And I think, it would be fair for an employer to ask whether those kinds of innovations are worth doing in an employee population that isn't going to stick around beyond 5 years. So that's one, is change takes time. I think two, to sort of build on the cliche here, is that the devil's in the details. So if you look at CMMI models that have a generation 1, a gen 2, gen 3, gen 4, many times the tweaks are very small And if you're not a policy person who's reading these policy documents in detail, they might look identical, but the small tweaks can often make a difference. How much is the incentive as a portion of total cost? Where and when is the incentive delivered? A great example of this is CMMI has a long history. Now, Medicare has a long history of operating accountable care organizations through the Medicare Shared Savings Program and many other tests. And one thing that CMMI did now many years ago was to offer upfront payments to certain ACOs that needed startup capital to be able to take on the risk associated with being an ACO in the first place. And that kind of change it's small, it's almost unnoticeable. It's money now or money later, it's the same money, but it made a huge difference for small ACOs that needed that help to be able to then take on those value-based incentives. So that's lesson 2. I do think, and this is the hardest one for this sector, the employer sector, but power in numbers. Every employer is doing this on their own. Any way that an employer has of building scale, whether that's working in markets of concentration, going to other employers, even competitors in markets where you're located to try to see whether you can't align your incentives, again, not on pricing, but on some of these quality and health outcomes, working with vendors that are interested in serving your entire population, even in different places, and the like. And then also, of course, working with health plans, which have the scale lever. I think that is absolutely key to so much of the innovation that seems to work.
Talk about the coordination with the carrier. Again, back to CMMI, this minor tweak to fund up front for the ACO, it has the ability to move the country versus on the employer side, again, back to each employer is its own employer, but does the carrier provide any kind of binding glue that will allow best practice to transcend and move across the broader carrier network? Or is this really the employer, not the carrier, that's driving the strategy?
Yeah, I think that's the $1 million question. Look, my belief is that the carrier can provide that glue. And I think there are examples of where the carrier has, some of the health plan design elements that we've been talking about are examples of a plan for a carrier saying, this is a product that's clearly of interest, not just to one employer, but to many employers in a specific market, in multiple markets. Let's offer it, and then people can buy it. And so I think there's an opportunity to do that. I don't think it happens easily. Again, health plans have a lot of components of their business that they're operating. And I think if I had a health plan counterpart sitting here, they would be quick to say, employers run their business, we administer it, but we don't design it. And so it really is up to the employer. I guess there's some hegemony in how we do health insurance in this country. There are variations on theme, but it sort of all looks the same. And I can't help but wonder, as we're seeing much more focus, especially in the venture and startup land, on offering customized products for individual populations, should we not see that translate into the insurance design as well, where instead of thinking about the core input for designing a person's health plan as where they work, do we think about what their care needs will be, what their family structure looks like, where they live, and which access deserts they happen to be in that limit their ability to access key care. All of these things should be inputs into a more customized plan design. And I do think health plans are an essential partner in that.
So let's talk from the perspective of small and medium-sized businesses, because a lot of what we've talked about really does require pretty sophisticated infrastructure, pretty big numbers in terms of local market density in order to accommodate an on-site clinic. And so what of this is relevant to small and medium-sized businesses? And within the employer market, is there a reason for hope for those small or medium-sized businesses, or is it really just we in that market are net recipients of healthcare costs?
Yeah, it's a great question. Look, maybe just to flesh out the challenge a little bit, small and mid-sized businesses don't have the scale of a large employer, so they are going to get probably a less good deal. They don't have the resources to devote to research, and so they are likely less educated on plan options that are out there, the newest plan designs and the like, than their jumbo those are maybe the two most important ways in which SMBs are at a disadvantage. Now, again, I'm an optimist, so I'm gonna lean into some positivity here. We have been focusing our SMB work in a couple of places. We've been building out a suite of educational tools because, again, SMBs aren't necessarily doing this research on their own for lack of resourcing. The research on their own for lack of resourcing, and so we're trying to supplement that with more education for SMBs, for business leaders, and for people who are in charge of picking health plan, health insurance, healthcare options. We're trying to supplement what they know with just more in-depth education. Two is many of these folks are working with a partner, broker, or somebody else who's helping curate a set of plan options for them and help them pick an option. What we heard from our survey efforts of SMB leaders is that they're spending precious little time with these partners, and they often feel like they're not getting real diverse options put in front of them. And so it's fair to say they think they're not getting as good a deal as they could for their employees. And so we've been thinking a lot about how to try to change that pattern, whether it's really thinking about the role that brokerage plays and helping educate brokers on SMB options, or, and this is where we've been spending a lot of time, really thinking about the options that SMBs have to start with and whether we can't improve upon them. Centivo, I mentioned earlier, they've been thinking a great deal about this, about how to serve SMB clients and their employees effectively and offer them more affordable, high quality options than they would get otherwise. There are many, many companies in that space, both on the alternative or disruptive brokerage side, and then also on the health plan side. And then the last piece here, we've talked in a few different places about the incentives that individual employees have to change their purchasing behavior. And I think the rise of the individual coverage health reimbursement account, or ICHRA product, is going to be another place where some of that dynamic plays out in the market, as some small and mid-sized businesses decide easier and better to just give folks money in an account that they can use to pick their own health plan options. I think we will see much more innovation in employee-directed health plan information options, potentially brokerage or other advisory services to help them choose the best option. And then, of course, all of the technology-enabled products that are out there that say, we're going to leverage AI to help decide exactly which plan is perfect for you based on your individual inputs. I think that's a space that's ripe for innovation and that SMBs can benefit from, even if it's really directed at their employees.
If JP Morgan or you as a representative of a large employer, it doesn't have to be JP Morgan, just an illustrative large employer, could ask for one change in the market, maybe one change from the payer side and one ask of the provider market that would be most meaningful and help move the needle most, what would those changes be?
I think I'd ask for the providers and the payers to come together to produce one standard price list that's payer agnostic, that's transparent and visible to every purchaser, both a scaled purchaser like an employer and also an individual consumer. So much of what we've been talking about is trying to solve this issue of prices are not transparent, they're not rational, and they're often not affordable. And I do that is, if I could wave my magic wand, I would do that.
Yeah, and look, that gives me optimism. I mean, I know that's a lofty goal, and I don't know that we hit that in the next 5 years, but I think it does underscore something we were talking about earlier, that a lot of the solutions exist in the market, and it's about then directing traffic to the right solutions, which is an incredibly complicated thing to solve for. But if I had to choose between finding the right directing of traffic for solution versus finding the right solution, I think I'd rather be stuck with directing traffic.
Totally.
And so you mentioned a couple times collaboration, coordination, whether it's between the employer and the carrier, whether it's between employers and CMMI, whether it's between the employers and providers, and I think that is, for me at least, where I'm most excited about innovation, the solutions that allow for that coordination to occur more transparently and more efficiently. And I think you mentioned Karen as an example of that, and I think that's probably a good one. What are the trends that you're most focused on over the next 3 to 5 years in closing?
Cool. Well, we've talked about a bunch of them. I do think we continue to be really focused on innovation in primary care, innovation in how people consume care. So virtual, text-based, AI-driven, self-driven, like technology where you can take a photo of yourself with your iPhone and it'll tell you what's going on diagnostically. There's so much innovation in primary care that we're paying attention to. I'm personally really focused on women's health, by which I mean, of course, maternal health, by which I mean pre-family planning stages. There's a ton going on with women that has nothing to do with having a baby, menopause care, and then also, of course, chronic conditions that present differently in women. Heart disease is a huge killer of women, and we really don't think of it as a woman's disease, which means we miss key opportunities to diagnose and treat women who die of a heart attack or a stroke. So just to name a couple of places where I'm really focused, certainly women's health is a category. And then, we're thinking a lot here about what happens in this next wave of innovation with episodic care. And, I think there's been a ton of research on workforce shortages really across the medical field. But I think, when you think about the fact that primary care is making so much less than specialists, we're trying to drive people to primary care, which there are just some incentives here that really need fixing. And I'm going to spend some time over the next 5 years really thinking about the next wave of innovation in specialist care, how we offer more care that might today be categorized as specialist, using other types of providers, both doctors and other professionals who can serve as providers to really get more specialist care into the hands of people who need it. 3 examples, there's many more, but maybe we'll stop there.
Look, we're really big fans of what you're doing. I think both from a practical perspective, but more importantly from a leadership perspective. I think the approach you guys have taken and transparency that you offer to the market to really take some of the experiments and initiatives that you're running and then promote the results and communicate the results, I think is commendable. So I really appreciate your time. I want to thank you for joining and very much enjoyed the conversation and learned a lot.
Thanks so much, Jason. It's been great to be here, and I really enjoyed the conversation as well.
Thanks so much. Take care.